the Thank you. So just a few housekeeping notes. Handouts will be available following the webinar today, including the resource list that will be talked about, and it'll be sent in a follow-up email. The webcast will be archived, as you just heard, and recorded on Zoom, and we will send out the link to the archive webinar following the presentation. Everyone's been placed on mute, and all microphones will remain on mute during the presentation. Please use the question and answer box to type in your questions. We will then read them out to the presenters during the last 10 minutes of the webinar. As well, there will be reflective questions included throughout the presentation this morning. A reminder to please complete the evaluation survey. As you can see on the screen, the link is there. You can also use the QR code. The Provincial Stroke Rounds Planning Committee uses the evaluations to plan our future programs. For you, you might find it helpful to reflect on what you've learned and how you're going to put it into practice. And of course, for our speakers, it helps them understand our participant needs and give them some opportunities for improvement. So please take a few minutes at the end to fill out the evaluation. You can complete it online, like I said, or you can email it or fax the paper evaluation filled in to the number listed that's at the bottom of the page. Certificates of attendance are available. A certificate was attached in the Save the Date email poster that was sent out. As well, it will be included in the follow-up email sent out following this webinar. Please fill in your name on the certificate and then keep it for future reference. Just flip to the next slide, Luciana, please. Just want you to know that the Provincial Stroke Rounds Committee mitigates bias to ensure there's no industry involvement or planning or education content of this presentation today. So if you want to go to the next slide, I'm happy to introduce both our speakers for today. Our first speaker, Dr. Catanese, is an assistant professor of medicine and neurology at McMaster University and a stroke neurologist and physician lead for hyperacute stroke services at Hamilton Health Sciences. She completed her residency in neurology at Boston University School of Medicine, followed by fellowship training in vascular neurology at Harvard Medical School. Dr. Catanese has participated in international trials testing novel therapies in acute ischemic stroke patients. She is leading quality assurance studies that evaluate the impact of acute CT perfusion on systems of care in the expanded therapeutic window. She's received several clinical teaching awards, publishes regularly in peer-reviewed journals, and serves on the editorial board of the American Heart Association Stroke Journal. Our second speaker is Jean Morrow. Jean is the Regional Education Coordinator from the Southwestern Ontario Stroke Network. She had a lengthy career as a critical care nurse and was the neurosurgical outreach educator for Southwestern Ontario for 5 years. She also currently is a professor at Fanshawe College in London. Welcome and thank you to both our speakers, and I'll now hand it over to Dr. Catanese.
Thank you very much, Sue. Thank you for the kind introduction and also the invitation to present today in these Provincial Stroke Rounds. This is a very hot topic that I'm quite passionate about, stroke and COVID-19, and I'm eager to show you the latest news that are out there related to the matter. So let's get started. I'm gonna show you some disclosures, particularly have to do with some operational grants. I received funding for consulting in a company, and of course, I'm the principal investigator of a cerebrovascular and COVID-19 study I will be briefly touching upon later during the presentation. So the objectives for my portion of the lecture are to explain the link between stroke and COVID-19 and review updated evidence, and also describe the impact of the COVID-19 pandemic on the delivery of stroke care. So how I outline my lecture, we're gonna start with a brief introduction and then dig deep into this link and all the evidence behind it, show you all we know about how the pandemic has impacted our healthcare systems, particularly from the stroke perspective. Just briefly mention our study, which is the only national study looking into the matter, and I'm trying to answer some important questions, and then we'll wrap up. So Let's start with some introduction. So, of course, in case you haven't heard, there is a pandemic out there that is caused by the severe acute respiratory syndrome coronavirus 2. That was first detected in December 31st in the Wuhan city of China. It since has spread throughout the world, as you can see in these monthly maps, in such a fast pace that is quite remarkable and sometimes difficult to actually witness and understand. There are almost 95% of the world has been affected and had basically confirmed cases. There are more than 18 million confirmed cases as of August the 3rd, with about 700,000 deaths. And as you know, the USA has been the hardest hit country by far, with 5 million cases, whereas Canada, let me just move here, yeah. Whereas Canada actually has seen a smaller number of confirmed cases after a very successful control of the first wave of the pandemic. And, you know, this has led us to understand, and it has become apparent, that this is not only a lung disease, and that indeed has direct effects in different organs, including the brain. Earlier reports, actually coming from Wuhan, have shown a 36% prevalence of neurological symptoms in COVID-19 patients, some of which I have listed in this slide. And we also know, and we're becoming more aware, that patients with COVID-19 had an increased risk of thrombotic complications such as stroke. Stroke is the most disabling type of neurologic complication of all, and also is the leading cause of severe disability in North America. So it becomes anything that can increase the likelihood of such a devastating condition immediately becomes a public health priority. But this is not all. This is not all of the story in stroke, as you very well know by now. There are a lot of indirect effects that are manifesting in a number of ways, and that can affect both our either patients, providers, or hospitals. And patients, for example, that have been affected by this pandemic are not seeking care due to the pandemic, and some of them, and that's mainly based on fear of getting infections while coming into healthcare facilities such as a hospital. And some of those patients who are indeed seeking care have more difficult access to it, as most of the outpatient facilities have been closed or reduced in capacity dramatically. From the provider perspective, there had been an overextended workforce that had been focusing mostly on COVID-19, and we personally, here locally at least, anecdotally, have been focused on COVID-19. Less so now, we're breathing in a little bit, but it was all about COVID-19 and nothing else. And that may decrease the efficiency to care for non-COVID-19 patients, which I will show you. I'll be showing a little bit more later on in the presentation. In terms of the hospitals have had major constraints, not only in resources, but capacity, particularly if you were in a hotspot. And there have been a number of protocols to implement physical distancing, and that have negatively impacted the care of those diseases, some of which are actually time sensitive and emergencies like stroke. So the effects on the pandemic at each one of these levels is what determines the true impact on healthcare, and what I'm going to be showing you with a lens kind of focus on what happened in the stroke world. So the coexistence of two quite significant diseases has created public health challenges that need immediate attention. We need to understand the relationship between COVID-19 and cerebrovascular disease, and we also need to determine and measure the impact of the pandemic on stroke care. So let's focus on cerebrovascular disease in COVID-19. So what we have witnessed is a rapid kind of a flooding of scientific information, trying to in an attempt, I think, to inform the medical community about some of the most concerning complications related with COVID-19. Now, What that has created is a lot of information that had modest to poor methodology, some anecdotal reports that may not have represented the natural link or the true nature of the link between these two conditions. So what I'm going to focus on is on the more robust facts, the papers that have the very sound methodology and that had the largest samples, in order to show you a little bit what has been more consistent in literature. And I'm aware that there is a lot more out there, but less impactful. So this is a truth. The true incidence of stroke in COVID-19 is still unknown. And why is still unknown? There are many reports out there and actually even some very large cohorts, but there are a lot of limitations to these. So we have to understand what kind of disease we have in front of us. So patients that have stroke and COVID-19 tend to be more critically ill. Critically ill patients sometimes do not receive as many diagnostics as patients that are less critically ill. There are a lot of patients, particularly we've seen this in the Italian cohort. They have multiple comorbidities, they are elderly, they are presumed to have poor prognosis, and therefore less life-saving care or invasive studies are done. And that decreases the chance of diagnosis. It's not only about diagnosing stroke, but also understanding what caused the stroke, right? That limits a little bit the ability to understand the link. Some stroke symptoms may not be apparent in ICU patients under anesthesia. Remember, these patients are critically ill and require heavy sedation to be able to be ventilated because of these the nature of the lung disease they get. Some patients are just not presenting to hospitals, as I'll show you. There's been also an increase in the proportion of patients that die outside the hospital in some communities, some of which is presumed to be from stroke and heart attacks. Some patients that have stroke do not get tested if it's not accessible. The overwhelmed system may not be able to accurately diagnose strokes, and this happened in New York City, for example, the peak of pandemic. And also there is a large variability across studies. So these studies have different methodology, prevalences, and disease severity. So of the population that they are studying, so it's difficult to really understand the true incidence. So we have conducted to try to answer this question an unpublished systematic review that shows a rate of about 1.5%. So around 1.5% of patients that have COVID-19 have strokes while they're hospitalized. And the big question to me is not whether it increases the risk of stroke, but is it different from other viral infections out there? Yes, COVID-19 is new, but influenza, for example, is also a viral respiratory infection that's been around for decades. This is a recent publication that actually tried to answer this question. And let me show you, this is a retrospective cohort study of 2 main hospitals in New York City compare the rate of ischemic strokes in patients with influenza A and B versus patients with COVID-19. They found that about 1.6% of patients with COVID-19 develop ischemic strokes versus only 0.2% of patients with influenza developing ischemic strokes. This actually translates into an adjusted odds ratio or an increased likelihood of 7.6 times higher of having a stroke if you get COVID-19 infection versus influenza. Now, obviously, there are the main thought is, well, is it because COVID-19 is a more severe disease rather than a true prothrombotic effect? Well, it seems that it's both. And I will show you a little bit about the stroke mechanisms in a moment. So what are the type of strokes that have been described in patients with COVID-19? And those are varied. Again, this is data from our systematic review that you will be seeing published in not a very long time from now. That show the vast majority of patients of strokes are the ischemic type. And these are almost 87%. And there are some specifics about the strokes tend to be more posterior predominant and large vessel occlusions causing devastating lesions, such as the one that you see on the left upper corner. 10% are hemorrhagic, And then 2% are of the subarachnoid hemorrhage type, or the more the venous type of strokes, which is cerebral venous sinus thrombosis, have also been reported in literature. This is, I think, to date, the best cohort that we have, not only because of methodology, but also because it's a large cohort. This is a retrospective cohort study of consecutive hospitalized acute ischemic stroke patients presented between March 15 and April 19, 2020, and they compared them against two different groups. One is patients that presented during the same time frame that had strokes but no COVID, and another comparison was historical. So they basically compare patients that presented with strokes in the same weeks but the prior year, and that is to account for seasonal variabilities. And why do we compare also with contemporary, so the patients that had stroke and came during pandemic? Because those are selected population of stroke patients. We actually think that the patients that came during pandemic are slightly different than the patients that actually regularly come, or at least could be different than the patients that come, and perhaps with a representation of more severe types of stroke. So it's important that those two comparison groups are there. And what they have observed is a low rate of confirmed ischemic stroke in hospitalized patients with COVID-19 of about 0.9%, and a median time from COVID symptoms to stroke of about 10 days. This is very consistent throughout literature, where thrombotic complications occur later on, about 2 weeks after the diagnosis of COVID-19. And this is no different for arterial thrombotic events, such as stroke. What kind of patients were this? Were these patients, as you can see in yellow, the demographics, and this is a table showing you the patients in each comparison group as well, and the p-values. You can see that they tended to be males, more likely to be young male, and 10 years younger than the regular patients coming outside pandemic. That they were more likely to have more severe stroke as per the NIH, 23%, basically an NIH of median NIH of 19 versus 8 or 3 outside pandemic, are more likely to have large vessel occlusion, so clogging of the bigger pipes, of 45% versus about 20%, which is the regular. What are the risk factors? Well, these patients actually tend to have less risk factors, less hypertension, less history of stroke when compared to patients that are outside pandemic, and they tend to have more hypercoagulable or coagulopathic changes with elevated D-dimers, elevated ERC showing inflammation, and elevated troponin levels. What kind of strokes these are? This is one of the few studies, really the largest one, that showed these patients got the workup, and actually the vast majority, 65%, were classified as cryptogenic strokes, and actually half of them met criteria of embolic stroke of undetermined source, meaning this is an embolic stroke, a blood clot that got lodged in the brain rather than originated in the vessels intracranially, or the small vessels in the brain, and these patients did not have atrial fibrillation, at least on initial screen. You can see how different that is from the regular kind of proportions that we're used to seeing on routine care. And the other thing is to know that, we do know that these patients that have stroke tend to be more critically ill, but they also had a 5-fold or 6-fold increase in mortality, in hospital death, which is quite dramatic. What about the strokes in and of themselves? So basically, these are the type of things that we are seeing, and it's becoming more consistent. So when we look at the blood vessels, these are cerebral angiograms of different patients with COVID-19, and I will show you a few more. You can see they have extensive clot burdens, as you can see on an A figure here. And this is a clot in the internal carotid artery. They are multiple, they are disseminated in different distal territories. They have tendency to fragment when they are trying to pull them out or retrieve. And they tend to have, at the end of the day, poor radiographical and clinical outcomes. These are more examples of a very interesting phenomenon that occurs. We call it this macrothrombosis. And this actually particular study reported this in patients that had mild symptoms. And initially, there was a kind of a train of thought with that, or a theory that said, okay, these patients have overwhelming inflammatory cascade and infection, and that's why they're having strokes. But when we see them, or seeing more and more in patients that are asymptomatic or have mild symptoms, that no longer stands, and it raises the possibility that there is more causing this thrombosis. You can see these clots tend to be attached to the vessel walls and tend to be large. These are large vessels. Again, this is a common carotid going into the internal carotid. These patients are treated with anticoagulants. Generally speaking, this is an example of an anticoagulant given for 10 days in a young patient without risk factors, and how the clot cleared without any evidence of dissection, for example, that could have caused such a picture. This is another 55-year-old male with a right common carotid artery into the internal carotid. Look how extensive the clot is. This is quite significant. Was given intraarterial glycoprotein 2B3A inhibitor, and the clot cleared a little bit. And lastly, a 77-year-old with bilateral DVTs, thrombosis in the common carotid artery. You see how big this clot is. She was treated with enoxaparin for 1 week, and the clot cleared. These are other types of findings we're seeing. This is a very interesting publication. I think it came not too long ago. 15 patients, an overwhelming majority having posterior circulation strokes. This is started to become, again, more kind of apparent. This patient, for example, this was a 57-year-old patient presented with altered mental status and decreased visual acuity. And you can see these kind of hypodensities here, posterior predominant, and they're also subcortical here. That is what we see with vasogenic edema. In this case, the patient had PRES, or posterior reversible encephalopathy syndrome. It's basically a loss of autoregulation, and is presumed to be due to the cytokine storm that is originated. They have normal vessels, and you can see here the hemorrhages in the posterior predominant areas. And this is just an MRI 3 weeks later showing the same. This patient is 67, who had right-sided weakness, left gaze deviation, and she had a PCA infarct. 10 days later, had more infarcts in the cerebellum, paracoccypal area, but on the other side, had a PCA occlusion, and then you can see how these strokes were bilaterally. And 6 weeks later, actually, she developed a bleed as well in the left thalamic region. Very interesting pattern. When we look about treatment, so how do these patients do? Are they different than patients that don't have COVID? Well, I told you already that they have higher reocclusion rates, but let's take a look. This is a nice publication in Stroke that came this month. And that shows the patients that are treated that have large vessel occlusions with COVID, they tend to be, that have more severe strokes that we have been seeing. The vast majority have mild or no respiratory symptoms, which is pretty interesting. They have multi-territorial large vessel occlusions more commonly. Early reocclusion rates, so when the artery is open, it keeps clogging up, of about 40%. This is comparing to patients that didn't have COVID. They have 27 controls. And although they can achieve successful reperfusion, these patients don't do well. They have more, they're more likely to get malignant brain edema, and they have a higher mortality, indicating, some other characteristics of the infectious entity playing a role here. This is a very nice, just published August 1st, proposed definition for what COVID-19 associated stroke should be. And I think it's useful because it has all the information together. And you can see here that for having a possible COVID-19 associated stroke, you have to have 2 major and 1 major and minor criteria. The major ones are having neurological and clinical evidence of stroke and having confirmed COVID-19 infection either by PCR or antibody testing, and having at least one of the others. The timing of stroke being a few days to 3 weeks, as we have seen, having lack or very few cardiovascular risk factors, and elevation of the diameter and LDH. And they go along and saying what are the supporting features when you have patients with COVID-19, and we have mentioned a lot of these, and the pathologic features of endothelial disruption, which have become very very well reported now at this point. So very useful to have as a summary of what the ischemic strokes look like in COVID-19. What about hemorrhagic? Well, this is even more challenging. So hemorrhagic stroke. So this is a meta-analysis that we conducted at our site. This is led by Dr. Catanese, who's an expert in intracranial hemorrhage, and was kind enough to give me some of this data. What he saw as the more likely incidence of ICH in COVID is around 0.5%, and this comes from Wuhan series. They still have to pull the data for the systematic review to understand the incidence, but patients appear to be younger than those with spontaneous ICH without COVID and tend to be more likely male. And I'm going to show you some of the most remarkable things and differences. Again, patients do not tend to have the standard risk factors for ICH, which is high blood pressure. You look at how different it is from actually the normal historical cohorts of spontaneous ICH. They tend to have inflammatory markers. Sorry, not inflammatory coagulopathy, markers with elevated INR and APTT. They tend to have more likely elevated D dimers, elevated CRP as a marker of inflammation, and have renal failure. 40% actually are on dialysis. You know, renal failure causes uremia, and uremia can lead to platelet dysfunction and increased risk of stroke, as well as is a trigger for high blood pressure, renal failure in general. These patients also tend to be on therapeutic anticoagulation. A lot of sites actually, standard of care, locally at least, to put patients on anticoagulation when they are critically ill. And these are critically ill patients. 90% have pneumonias and 74 require ICU versus 15. And how the bleeds look? Well, they are mostly lower in the surfaces of the brain. And they are multifocal and they involve multiple compartments. And let me show you an example of the bleeds that are being seen. These bleeds that have these fluid levels. I don't know if you can see here. You see the fluid levels. So there and there, these are multiple lobar bleeds, bilateral. They have some subarachnoid hemorrhage associated with them. They can be parenchymal and intraventricular because they extend, but it's very specific, the look of these intracranial hemorrhages. Some of the entities that are associated with intracranial hemorrhage in patients with COVID are immune thrombocytopenic purpura. There are a handful of reports now where patients that have COVID within the first week or so develop the lower extremity purpura, as you can see, and the epistaxis because the platelets drop dramatically. These patients are treated with IVIG. And the other one that is very interesting is something we already have seen as a complication of influenza, which is called acute hemorrhagic necrotizing encephalopathy. This is a type of encephalopathy that is thought to be caused by the cytokine storm, the inflammatory response that a virus triggers, that causes disruption of that blood-brain barrier. It breaks the blood-brain barrier, and it can cause actually necrosis and edema. As you can see here, it has a predilection for the bithalamic brainstem structures. As you can see, they generally look like this, and they're associated with bleeding. There is also a thought that they could be direct viral invasion. We're seeing a lot of pathological studies now showing viral particles inside the neurons. And this is something that is certainly possible. And I'm showing this because I don't want you to get completely full about some of these reports. So some reports are showing critically ill COVID-19 patients with things like leukoencephalopathy, which is the hyperintensity in the subcortical structure, as well as microbleeds, that these little tiny black dots that are juxtacortical and tend to invade to be present in the corpus callosum. Well, keep in mind, these are critically ill patients, a lot of which require ECMO. They are on blood thinners, and these have been widely reported in literature. This is critical illness, and this is the brain of people that are critically ill, and not only COVID-19. These patients have this type of what we call sometimes post-hypoxic CMBs, but we don't really know why they occur, but it's the same pattern as have been reported in COVID patients. To me, no different than critical illness CMBs. In the same way, they have been reported post-hypoxic leukoencephalopathy in patients that are critically ill that looks like this. And we know COVID-19 can cause severe hypoxemia in these patients. 2 words on stroke mechanisms. So basically, instead of stroke mechanisms, other mechanisms proposed for ischemic and hemorrhagic strokes. I think this could be a lecture on its own. But I think it shines a light on this association. So the potential mechanisms, you know what, the main thing is, well, COVID-19 related cardiac and systemic changes that you can see in the red center, circle in the center, could potentially promote all type of strokes. These are all the type of strokes: small vessel, cardioembolic, large artery, undetermined, other types of stroke. The attributable risk is expected to be greater for other types of strokes and cardioembolic strokes. And why is that? Well, because the main mechanisms are presumed to be 3 of them. Number 1 is a hypercoagulable state. So COVID-19 triggers or is associated with this hypercoagulable state where you have incredibly high D-dimer in the thousands, elevated APTT. Some patients have thrombocytopenia, and late in the disease, the fibrinogen starts to deplete. Now, even though the fibrinogen starts to deplete, very rarely patients have actually overt DIC. The thought is that this is a different type of hypercoagulable state triggered by the virus itself or the inflammatory cascade. Some patients have positive antiphospholipid antibody triggering hypercoagulable state, but the phospholipid antibody are also found in critical illness again, so it's hard to know whether this is a true cause for this phenomenon. The other thing is that these patients can have vasculitis due to direct viral invasion of the endothelium or as a result of systemic inflammation. And it hasn't been elucidated whether it's one or the other or both. And lastly, but not less importantly, is patients have or can develop cardiomyopathy. There are reports of direct viral invasion. The heart can also be affected by hypoxia and inflammation, such as the brain, but it can lead to myocarditis, heart failure, and arrhythmias. In terms of the hemorrhagic side, well, this is a little bit more confounded by the fact that, and I'm gonna refer you to the number 4 point, because I mean, just keep in mind these patients are in therapeutic anticoagulation, some of which are in ECMO. And they have multi-organ failure. Liver and renal failure can just increase your risk of bleeding, like liver renal failure from sepsis. So this is a little bit different, but the proposed, the pathogenesis of hemorrhagic stroke in the setting of COVID is thought to be related to, again, these 3 main things: direct viral invasion as through the ACE2 receptor, which is present in endothelial cells and arterial smooth cells, basically can destroy that cells and cause bleeding into the brain, and the cytokine storm, which can damage the blood-brain barrier and cause this hemorrhagic type of posterior reversible encephalopathy syndrome, or also through the acute necrotizing encephalopathy that I have shown you. Of course, there is hemorrhagic transformation ischemic stroke or cerebrovenous sinus thrombosis, but those are secondary kind of causes of ICH. Okay, switch gears. Let's look about the negative bystander effects of the COVID-19 pandemic on delivery of stroke care. So I'll show you lots of the direct effects and how frequent they are and how they can look. Let's take a look quickly of these other implications. So basically, there have been a lot of implications in healthcare with the epidemic control that had taken place in order to try to flatten the curve, right? So some of the measures include strong physical distancing measures, increased hospital capacity, redeploy staff, limit number of workers in one space, enhance disinfection, sanitizing, using of PPE. The non-essential care had been canceled and hospitals went in lockdown, and it all occurred fairly quickly, again, in order to prevent the spread of disease. Now, very quickly as well, we started to hear reports like this. Somehow we were seeing fewer heart attacks and strokes as the coronavirus pandemic stuck, and nobody really knows why. So there are some theories out there. So there are some experts, particularly from Yale, New Haven, who had published a little bit about the topic, and they suspect that in like 80% of the times, because patients are avoiding emergency department care due to the fear of infection, and about 20% of the times is because of lifestyle changes. And this is interesting. So yes, we have seen there are less crime, less car accidents during the pandemic, less premature births, but how has that affected stroke? So let's take a look. So this is one of the earlier publications in New England Journal of Medicine that showed actually how the pandemic had impacted the stroke cares in stroke. This is from 856 hospitals in the US, with more than 230,000 patients, showing you here the daily count of unique patients who underwent neuroimaging with rapid software for stroke in the United States. The shaded regions correspond to the pre-pandemic times in blue and the pandemic times in yellow. And you can see they found the collateral effect of COVID-19 has been a decrease of approximately 39% in the number of patients who received evaluation for acute stroke. And this decrease was seen across all ages, sex, and stroke severity subgroup in all states. Quite a dramatic. Now, true that they use the utilization of imaging as a surrogate marker of stroke presentations, but still it does support the fact that more likely patients actually did not present as often as previously. So we replicated this. We, with a group of people from UHN around the Ontario region, some of which may be on the line perhaps today. We took also rapid unidentified anonymized data from 4,000 patients from 8 hospitals in Ontario. And what we saw, this is from the pandemic time, with a comparison previously, it goes from December 1st to May the 31st. And what we have seen is that there has been a significant decrease in stroke presentations across Ontario, with a 44% decrease relative decrease in the number of scans per center per month, without any differences in the areas of infarcted tissue. So these patients, there was a thought that patients that came to the hospital actually had larger infarcts, and that's what they came. We didn't see that. And I think, you know, this has important implications for public health policymakers who may need to consider, you know, better measurements to educate and inform the public on the importance of presenting promptly to the emergency department if there is a signs of stroke, regardless of whether we are in a pandemic or not. More data here from Cleveland, Northeast Ohio, just came out this month, again showing a significant decrease in acute stroke alerts by 30% across emergency departments at the time of COVID. You can see the correlation between the solid black line, which shows you the stroke alerts, and the second line, which shows the telestroke consultations as the pandemic raged throughout that region. Not a lot of change in the delivery of TPA and EVT. They did see this initial drop in TPA, but EVT had remained fairly consistent. This is actually from across the globe, from Spain, seeing similar findings, because we always wonder whether in North America we're doing something different. But Spain, they saw a 25% reduction in stroke admissions, and they also saw a drop in TIAs specifically presenting to the hospital or to the emergency room in this case. There is a very nice editorial about the curious case of the missing strokes during the pandemic that talks about a little bit what are some of the thoughts behind it. Well, mild strokes may be remaining at home is possible. There is a thought that social isolation, particularly in the elderly, may have caused unrecognized strokes in this population. It's true that in the hotspots, overwhelming EMS transporting patients to closest hospital rather than stroke centers. This is an overburdened, overloaded system. And there has been reported low stress related to commuting and work, although I think pandemic has increased the stress in other ways. So not sure what the actual balance is about stress, but certainly less related to commuting and work, and less air pollution. That may have reduced the incidence of stroke. This is actually data from Ontario. Looking at air pollution, you can see pandemic emergency declaration. Sorry, pre-emergency declaration, even pre-emergency declaration, and more kind of striking during the state of emergency in Ontario, we see the ozone going up and the polluting particles going down. Now, what's the correlation between this and health? Unknown, but again, these are all observations and indirect changes that have occurred during this interesting pandemic. This is showing for the first time, get with the guideline database, again, the pandemic control compared to historical. The main thing about this study is showing for the first time that there was a delayed presentation to the emergency department. There was a 160-minute difference in the time from the patient having the symptoms to the time they presented to the emergency department. And you can see how different this is during COVID and versus without COVID, which is quite actually sad to see. This is our own doing. We looked at in-hospital delays for acute stroke treatment at Hamilton General Hospital, being published today, Canadian Journal of Neurological Sciences. We look at pandemic versus pre-pandemic times. We actually didn't show any trends. We didn't see any trends in stroke admissions pre or post-pandemic, but we are set to see actually striking an increase in door-to-needle time that actually doubled the general, 61 minutes versus 39, 39, 35. And you can see in April, we're coming back now to normal. We're keeping a very close eye on this. And that's mainly driven by the first encounter being delayed, which is the time the patient comes to RED and gets a scan, because there are multiple protocols that can take place. We assume patients have COVID-19 when they come in. And you can see, I think the interesting part is it started happening early March, even before the declaration of emergency. And I can just tell you how just the information around can impact the way we behave. This is from CHUM, I think also published this month, shows the same delay in presentations to ED, delay in getting imaging. They also saw almost more than double, like we did, and delay in recanalization rates. I think this is one of the most important things. I'm actually pretty devastated to see this, because someone who's working day and night to improve these metrics, for it to go so bad is tough. And I think, it's important to know that the public health and institutional restrictions that are imposed in response to COVID-19, though they are necessary, they're certainly necessary, they can as well have a collateral damage and cause a negative impact on the delivery of stroke care, and that predicts stroke-related outcomes. So, you know, being able to understand where those delays are at a national level and work diligently to improve the treatment times, and it's going to reduce disability from this devastating disease, and it's something that is worth our time, at least my time, I think. So this is what we're doing. This is what I've been doing on my spare time during COVID pandemic. Besides building algorithms, we put together a national study along with UHN. This is the only national prospective multi-center longitudinal study that is trying to address these important questions. We're characterizing stroke and COVID-19 disease in Canada and determining the outcomes of the patients that come during pandemics that don't have COVID but have stroke, and how the pandemic has impacted the delivery of stroke care. The main goal, those are the main goals, but the overarching goal is to really come together with national collaborations and pull data together. Because remember, in Canada, our success is our weakness, in the sense that because we control the pandemic, we have less stroke cases and we have less to kind of understand this link. We're gonna collaborate with other international studies to try to answer these questions by the end of the year. So this is the inclusion criteria. This is our website that has everything you need to know, and yet we have already 10 comprehensive stroke centers in our study. But if you're interested to contribute, then we'll be happy to have you, and please contact us. Lastly, this is very nice read. This is some guidance to tackle some of these issues in stroke care that came up this month, or just yesterday, maybe. I think so. It's worth reading, and it gives us some, ideas on how to be efficient during pandemics. So summarizing, COVID-19 increases the risk of stroke, but the risk is still relatively low. Ischemic stroke patients with COVID-19 are younger, with higher NIHs. They have mostly the undetermined types. They have high clot burdens, multiple blood clots, and they are hard to reopen. The mechanism is a combination of things, including inflammatory states, endothelial injury, and cardiac injury. For intracranial hemorrhages, again, these are younger patients without or with less risk factors. They have very strange multi-compartmental focal bleeds with lower predominance. They also have high inflammatory D-dimer markers. Frequently, they have renal failure and an anticoagulation. The mechanism is presumed to be multifactorial, as I mentioned. In terms of the pandemic delivery of stroke care, we know the health collateral effects are vast. There are variations that are regional, but overall, we had less stroke assessment, less admissions, delayed symptom onset to presentation, similar proportion receiving treatment for those that come, and delay in the treatment itself. So our understanding is rapidly evolving. Again, our success in Canada is our weakness in terms of research. So we need to do multi-center research collaborations. And our study, funded by the Canadian Stroke Consortium, will try to characterize and answer these important questions in Canada. Thank you very much. And I'll pass it along to Jean.
Hi, thank you very much. I see that we only have about 10 minutes left, so I will sort of just quickly jump through so that we've got a bit of time for questions and answers. And okay, and so I was going to provide a bit of information on websites and resources that healthcare providers can refer to that have up-to-date information on stroke and COVID. I've provided a number of links that I'll give you on a handout that you can receive in the customary post-event follow-up email that will come out later today. Or if you're not on our email list, those of you that have dialed into today's presentation, you'll be able to request the handout in the follow-up Zoom email that will come to you tomorrow. So those of us that are working on the front lines, some of our workplaces have been impacted, obviously, by COVID, and we find ourselves sometimes working with people that aren't familiar with the specialized stroke care that needs to be provided. So, you know, imagine that you're at work one day, you find yourself suddenly with unfamiliar staff who are new to caring for stroke survivors. You get out of report, somebody asks you if there's anything special they need to know about getting up their patient to the bathroom for the first time, somebody that has significant weakness, or maybe another colleague approaches you and asks you about specific routine stroke care that they should be providing to their patient. Where are you going to turn for resources, and what information do you have handy that you can access readily to support the new staff? And so when COVID happened, it sort of swept in like a big wave. You know, everything stopped overnight, surgeries were suspended, outpatient appointments were halted, hospitals came up with contingency plans, and some of them actually, you know, we didn't see the huge surges of COVID patients we were expecting, but some patients were moved to other areas to make way for the onslaught of patients we thought were coming. And so in the wake of all of this planning and movement, you know, we began to think about how do we support people that will be unfamiliar with stroke patients to care for those patients. So system planners, partner organizations, anticipated needs, identified gaps, and got to work developing resources and materials to meet those needs. You know, and as materials and programs shifted and became available, websites were created, and information was pushed up online so it would be available for those of us practicing on the front line. So here are a few of the key websites that you can go to get up-to-date information and resources on stroke, obviously, and COVID. Some have information just for healthcare providers. Others are for patients and families, and obviously some service both. So there's lots and lots of websites. I'm just sort of highlighting a couple of key ones today. So the first one, the first resource that I want to talk about. So if you find yourself in a situation with a stroke that's new to caring, with staff that's new to caring for stroke patients, and they need a quick rundown on sort of what they should do, you know, with respect to transferring or moving, communicating with the stroke patient. How should they care for the upper arm extremity? The Heart and Stroke Foundation has condensed their tackles resource into acute quick reference guides. You can find these on the Heart and Stroke website. And really they're just 2-page handouts that provide key information, and they're all based on the Canadian Stroke Best Practice Guidelines. There's 6 guides that they've made available. So you can see the 6 on the slide here. And they have been condensed from that larger tackles printout that's also available online. In addition to these 2-pagers, they have developed what they're calling Tackles Acute, and really what this is slide decks that provide all the information. So they're quite lengthy, they're up to 60 pages, and they're much more comprehensive than the 2-pagers, and they cover more topics. There's more than what you see listed here on the page, but essentially you can download it, staff can refer to it, and it really is an excellent resource if the staff member is new and they want more detail, or even yourself for your own learning. Another resource that's been developed, and this is quite excellent, and it really has been developed to support staff that's new to caring for stroke patients, are these quick reference sheets. They are specific to a variety of professionals. So there's sheets that have been made for the occupational therapist, the physiotherapist, nursing, social work, and the SLP. Many of the stroke networks across Ontario have created their own specific reference sheets for the regions, one for each of those professions. Here's a couple of examples up on the page here. One is from the Toronto Stroke Network and the other from the Champlain region. And they really provide a nice summary of guidelines for stroke care. It really is sort of a quick and dirty all in one place, and it gives that new person information on what the usual care should be, what are the markers, and there are links to more details and more information within that. So these can be found on the Core Health website, and they're also located on several of the local stroke network websites. So if you've got a healthcare provider that's new to stroke, that's working with you, these are excellent resources for them to refer to. Speaking of the regional stroke networks, many of them have developed their own websites that provide useful COVID and stroke information all in one place. They're filled with links to local and provincial and national information, and they contain very useful descriptors that are easily navigated. So if you don't know where your stroke network website can be found, please reach out to your district stroke coordinator, or you could reach out to one of us and we'll help you to get connected. But lots of great information, and they're each all a little different. So if you haven't been to the Core Health website, they have a COVID-19 resource center there. And so you can narrow it down if you want cardiac or stroke or vascular resources, because of course they do all three. But it really is a robust hub for links and resources that relate to stroke and COVID-19. And they developed this resource to share the most recent updates, obviously on COVID-19, and this is updated regularly. Right, and here's sort of a snapshot of what you can find on the Core Health website. Things are nicely laid out. You've got quite a robust array of materials that are available, and they continue to update this as new resources become available. One of the other resources that I think is particularly helpful, especially if you've got a patient or a client that has aphasia, or maybe someone that you're having a difficult time communicating with, are these participant resources that have been developed by the Aphasia Institute. So they have a number of COVID-specific communication tools that really help support conversations about a variety of topics, such as healthcare has changed, COVID-19, what to do, consent to online programs, going to the hospital, going to rehab, residential facilities. These documents really help to support communication between aphasic patients and others, and certainly while training for supported conversations for people with aphasia is really helpful when utilizing these tools. They're available for anyone to download and use, and I would encourage people to do that. Another excellent resource that stroke survivors and families can use is this practical video from Heart and Stroke on how to wash your hands when you have one arm weakness or paralysis. Obviously hand washing and masking are two key behaviors that really do reduce the spread of COVID-19, and clearly it's difficult to wash your hands effectively when you do have one arm weakness. This is a great video. It's 4 minutes long. You can link to it from the Core Health website, and it's a fantastic resource for patients and families. And then the final resource that I wanted to highlight is the After Stroke virtual stroke recovery programming that the March of Dime has done. If you've never been to the After Stroke website, it is a fantastic resource for patients and their families. They do a lot of in-person meetings and support groups. They have transitioned all of that to virtual. So it's all online now. They use Zoom. They help people get set up. You can see the list of programming that's ongoing and available, so it is quite robust. And they really are working to find ways to plan activities to keep stroke survivors and their families connected, to help them integrate back into communities. So there's a lot of other excellent resources that are out there. I hope I've given you a couple of tools that you can take and put into practice. This last snapshot here is just a very small sampling of what's available on the Core Health website. Should you go there and link to see what's around, I really encourage you when you get the handout with the links to explore some of those and to take some time, because there's a lot of great information out there. Thank you.
Sorry for running into your time, Jean.
It's fine.
These resources are amazing. I train in the US and then tend to go to American Heart. These resources are particularly well put and thought out. I highly recommend them. I do use them all the time.
It's Barb Kubilis, the Regional Stroke Education Coordinator for Central South. I'm just moderating our chat. We have lots of questions about how do we get the resources, how do we get Dr. Catanese's presentation, all that. We are going to send you all that information following the event later today or tomorrow. If we have time for the answer, I know Dr. Catanese has tried to answer it in the chat, but we have one question about, can you explain more about D-dimer and elevated troponin as main diagnostic test for stroke? You started to answer it for us.
Yeah, so I was just saying, thinking this is related to COVID-19, right, or just stroke in general. So, so elevated troponins are not frequent in just regular stroke, but they seem to be much more common in patients that have COVID-19. The thought behind that is there are two different mechanisms of injury to the heart in COVID-19. One is the cytokine storm that occurs that affects myocardial cells, and the other one is that the myocardiocytes have actually ACE2 receptors, and they invade. There is direct viral invasion that has been documented, generating, you know, this inflammation and heart failure arrhythmias. The D-dimer is a very interesting thing. So we have debate with thrombosis experts here at McMaster. The thought behind that is that, you know, the D-dimer is a product of degradation when you basically cleave fibrinogen. Fibrinogen is activated into fibrin when you have a hypercoagulable disorder. And it's incredibly high, but actually DIC, diffuse intravascular coagulation, which would be one of those moments where we see elevated D-dimer and low, for example, fibrinogen, is actually rare. So we think actually the hypercoagulable disorder is because of the phenomenon the virus causes, mainly driven by, again, an overwhelming inflammatory response that activates coagulation.
Great, thanks. This is Sue Verrilli, and I'm going to wrap us up for today. We've gone over by 2 minutes. I apologize. I want to thank Dr. Catanese and Jean both for your excellent presentations. It's a very scary and interesting time, and we'll watch for further research coming out. Just to remind the participants today, we're going to send out a follow-up email, and it will have a number of resources for you, including handouts, the resource list, certificate, archive webinar, etc. Our next Provincial Stroke Rounds will be held on Wednesday, September 2nd. The topic is Why 911, and it's being presented by Dr. Hassan, Christina Visser, and Kelly Cristofaro from the Northwestern Ontario Stroke Network. Thanks for joining us today, and stay well.